a cargo del doctor Thiago Alves Pinto de Brasil. Él es patólogo, miembro de la Sociedad Brasileña de Anatomía Patológica, máster de Ciencias de la Universidad Federal de Goiás, preceptor del programa en el Hospital Base del Distrito Federal, patólogo de laboratorio diagnóstico. Y nos va a presentar test de EGFR molecular totalmente automatizado, una experiencia de un laboratorio brasileño. Quiero hacerles notar que esta va a tener traducción, pero los principales conceptos están en las diapositivas en español para que la vayan siguiendo. Así que adelante, doctor Alves. El espacio es suyo. Ready.
Good afternoon. Everybody's here. Sorry, everybody's hearing well? Is listening well?
Yes.
So, good afternoon. First, I would like to thank Alatheia by this inviting. Hopefully everybody's going well today. And I would like to congratulate all the presenters until now. And first, apologize for not speaking in Spanish, but I'm trying to make an understandable presentation. Overall, I'm pleased to meet you today, speaking about this compelling topic. I must recognize that I'm really impressed how this technology can help some patients. Here are my conflict interests. So currently, personalized oncological treatment is guiding decisions even more than in few past years. High-precision medicine demands much more comprehensive molecular tumor profiles. By the way, next-generation sequencing could answer many questions. However, it's time-consuming and costful in terms of infrastructure and staff. So, what could be done to abbreviate time while maintaining confidence? Nothing is better to answer this inquiry than showing a real clinical case. This woman, 57 years old, weighing a stable 72 kilos, married, holding a history of rheumatoid arthritis, in use of hydroxychloroquine and azathioprine for 10 years. She has a history of a vaguely described asymptomatic lung fibrosis, probably related to her immune disease, and she has coursed with slight flu symptoms 10 days before appointment, having dry, progressing to productive cough, and she has complained too of some ailments devoid of fever, and she had denied hemoptysis. She told has faced a stressful event at work a few days before, and started feeling a chest pain. She has presented to the emergency room, where has been realized a thoracic CT, which has shown the following findings. Here you can see a spiculated nodule located in the left upper lobe apical posterior segment, measuring about 2.3 per 1.7 centimeters. It was found among ground glass opacity and enlarged lobal saps. It was deemed as highly suspicious for malignancy and for lymphangitic carcinomatosis. It was asked a PET-CT, and a transthoracic lung biopsy was feasible, thus recommended. The PET-CT has shown a multiple highly FDG uptaking thoracic lesions and multiple metastatic backbone lesions too. The core biopsy has been done and sent to the pathology lab. Now, I'd like to reassure how important are pre-analytical steps. Fixation by buffered formalin is one crucial step in preparing specimens for microscopic examination and molecular tests. It would not only prevent decay and preserve cells, but also conserve genetic material. Here you can see 3 HME standard sections containing material of the 3 different FFPE blocks. Dividing up to 2 core biopsies for each block, like here, is an essential strategy in order to conserve tissue for each necessary procedure to molecular tests. In the tissue section has been detected an invasive adenocarcinoma in approximately 80% of the sample. This percentage is used to guide how much of the sample would fit the generic material input requirements of molecular methods. In detail, we can see the papillary and acinar architecture. The case was positive for TTF1 and for napsin A, supporting lung origin. ALK5A4 was negative, and here you can see HOS1 faintly labeling that was deemed as negative by the IALS atlas. All the line of action described until now with the sense of safeguarding biological material and rendering timely results. Once the patient in question had a high metastatic disease with both lungs compromised, the oncologist has asked promptly.
Yo creo que es de tipo intestinal, Sol. Estoy segura que lo debo haber visto en alguna parte porque también pensé lo mismo. Y
disculpen, ¿se están escuchando las traductoras? ¿Por favor, silenciar el audio?
Yo no tengo audio. ¿Lo prendiste?
Sorry. My screen. Could you confirm? Everybody see?
Yes.
So I'm going to continue. By taking solely one rolled tissue FFP section of the appropriate length and thickness and adding it into the cartridge, a lab technician could start a Idylla run. These steps takes less than 2 minutes on institution. This such small footprint equipment is placed in the immunohistochemics room. Inside the equipment, many molecular steps works following a strict path, leading to finally real-time amplification and detection. The Idylla EGFR is a comprehensive assay with 51 EGFR mutations coverage. Within only 2 hours and a half, it is possible to release an extremely careful result by an equalized technology. When talking about liquid biopsies, it is as simple as the FFPE preparedness. Nevertheless, the patient blood must be collected, either in EDTA to be processed within 4 hours, or in special tubes to be processed within 3 days. As I said, it's necessary only to centrifuge the blood, pipette the floating plasma, and deposit the enough quantity inside the specific cartridge. Finishing setting up the console, and roughly with about 1 hour, the machine would release the results. So, by doing each and every procedure inside the same cartridge, Idylla is able to give fast results at the same time of the pathological and immunohistochemical results. On the other hand, lab doing standard qPCR or NGS needs much more expensive infrastructure, a highly specialized staff, and cost-worth consumables. Not even talking about contamination chances and hands-on time. That's why 2 years ago, studying the theme, we decided kicking off on the field of molecular pathology by the Idylla platform. It has given us confidence, showed our oncologist partners our aim to give whole results in short time. And more than it has given for patients the opportunity to be treated and recovered, not only those one harboring lung cancer, but those harboring melanoma and colorectal cancer too. Moreover, thicknesses and large mutation coverage. This study from Italy has recently compared the efficiency between Idylla platform and NGS platform. While the Proton NGS platform, 2/3 of the sample, resulted in success reports, Idylla detected not only those 43 samples, but also had more than 90% of success in these tests. Although NGS is comprehensive and it seems that this technology needs a higher quality and quantity of material to report valid results. Idylla could work across fresh frozen tissue, fresh touch prepares, and cytological samples, presenting a high concordance with reference methods. In summary, despite detecting a wide range of novel mutations, the next generation sequencing often translates into long turnaround times. In contrast, Idylla system facilitates assessment of key molecular markers, which can be used concurrently with NGS. Ideally, both methods could even coexist, by Idylla results being released. Besides pathological and immunohistochemical reports, the oncologist is able to start patient's treatment, while NGS lab could have enough time to search for actionable variants not described at this first approach. A large academic center from New York has tested this by comparing Idylla containing workflow with a standard molecular testing, both of them preceding the NGS, showing that turnaround time for rapid EGF testing reduced from 9 to 1 to 3 days using minimal material, allowing thus further testing by NGS assays. So summarizing the case, it was detected a L858R mutation. It was detected only 2 days after the biopsy by the Idylla platform using the FFPE tissue sample of the patient lung cancer. This EGFR result was released in the same day of the immunohistochemical test, some hours later. After promptly starting the treatment using osimertinib, the oncologist sent the tumor sample to Foundation 1, which confirmed this mutation, releasing their result only 1 month later. Seeing how interesting Idylla platform is, we would like to offer those tests for all cancer patients. Unfortunately, Biocartis offers a limited range of cartridges, as you can see here. They explain that it isn't easy to standardize, validate, IVD approve, and offer a so straightforward method. But they are working on new cartridges as a gene fusion panel 1, which is hopefully expected by us. Here you can see the PET-CT again, the first assessment, and how the patient was 4 months later. You can see that all lesions have vanished. So many of our EGFR tests today are being made for metastatic patients at the diagnosis, needing promptly response. As this perfect one you can see here. One interesting point, which I couldn't ignore, is the one that was not few days after the oncologist has called me telling the patient has completely recovered by clinical and immune methods. I was invited to tell you our experience regarding this platform, so I couldn't miss it out. Nevertheless, it's good to bear in mind that osimertinib has been FDA approved as adjuvant treatment. Therefore, last month, we are facing new demand for testable specimens of early stage disease, no more only metastatic ones. So, having you any doubt or interest on the technology, please contact me or Alatheia staff, respectively. Thank you. It's been a pleasure.
Thank you very much, Dr. Alves and Alatheia, for your presentation. Ahora tenemos un muy breve receso y luego vamos a continuar con las charlas de la doctora Fátima Carneiro, que estamos seguros que muchos las están esperando con ansia. Gracias.